It's a great pleasure to come here, and thank you, Himanshu and Dr. Noori, to have invited me to come here. I added these two slides in tribute to Dr. Hilaris. I missed him yesterday. This was a photograph taken in 2002 and 2003, and he was the first one to use intraoperative radiotherapy with target technique in the US. So I understand he was given a Lifetime Achievement Award, so feel quite nice that this was one of the things that he envisioned would be the future. So I shall talk about TARGIT-A and TARGIT-B trials. So it started for me with a concern for patients who presented to me as a chief resident in Tata Hospital in Mumbai in the 1990s. These patients had small lumps. They could have lumpectomy, but they couldn't have breast conservation because they had to stay in Mumbai for 6 weeks. So they had to go back to their hometown. So we said, okay, now you need to have a mastectomy. So the first question is, can you stay in Bombay for 6 weeks? And if the answer was no, they had to have a mastectomy. And that wasn't a very nice thing to tell. That was the first thing that was taught to me as a resident when I started in Tata Hospital in breast unit. But simultaneously, there was curiosity that whether a breast with one cancer has more than one cancer. And we knew about the work of Professor Roland Holland, in which he did find these. So I did this work in Tata Hospital of doing the mastectomies in the operation theatre. By the way, I'm a surgeon, so it's important to know that. So I would operate, the patient, take the mastectomy to the lab, freeze it, slice it every 5 millimeters. Before I sliced it, I marked XYZ coordinates and take tissues from every one of these slices. About 22 on average from each slice. I knew all the X, Y, and Z coordinates of these tissues. The pathologist would examine them, and the position of where these are taken were taken because I took mammograms of the specimens. And when analyzed in 3 dimensions, this was done for the first time, we found that these are present, extra cancers are present in breasts of this patient who have supposedly had one tumor in other parts of the breast. And they were distributed all over the breast. So the natural conclusion would have been everybody should have a mastectomy, and breast conservation is not a good idea. However, we also know from breast conserving surgery trials that if recurrence occurs, it occurs around the tumor. Whether you give radiation or you don't give radiation, it still occurs around the tumor. So this is when I presented this in 1995, almost 20 years to date, that although diseased breast has many widespread cancers, most recurrences occur around the tumor, and that could form the basis of a clinical trial to test whether radiation around the tumor was good enough. And I came to Royal Marsden to work with Professor Baum and Professor Tobias. We managed to make a device to test this idea. So it was the academic insight that led to collaboration with the industry to make a device in order to test the hypothesis, which led to the clinical trials, TARGIT-A and TARGIT-B, based on the idea that we would like to give radiation more precisely and immediately after lumpectomy. So the TARGIT technique was developed in 1996 to 1998, and you probably are aware of this technique. This is a 50 kV machine which generates electrons which hit the tip, which is a gold tip, generating X-rays at 50 kV. And the dose distribution corresponds to the risk of recurrence rather than the probable possibility of multicentric cancers. So the procedure is relatively straightforward. After a lumpectomy, you choose the correct size applicator. They go from 2.5 to 5 centimeters. Insert it in the breast. This was a photograph taken in 1998. And you position it such that the tumor bed opposes the applicator. To test, we first tested this in 1998 to 2000 to see if it is safe, and in 2000 we launched the TARGIT trial, asking the question, is this therapy enough? So this trial, as you know, was recruited in 33 centers in 11 countries, started in Europe, but also was many centers in Australia and America. This is the International Steering Committee, and these are the centers who participated. So acknowledgements are due to all patients who participate from these centers and all the investigators. So the trial from 2000 to 2012, as you can see, the accrual was slow in the beginning, but then picked up rapidly after 2004. And in 2010, we reached the accrual goal of 2,232, and we published in the Lancet with the first results. And there was a lot of publicity around at that time. But we decided to continue randomization. So we continued from 2010 to 2012. The trial closed in 2012 with 3,451 patients. It was one of the large trials asking this question. And we published the results of, first results of survival and the second results of local recurrence last year in the Lancet. And in 2010, we were quite pleasantly surprised that Lancet put our conclusion on the front page of their July issue. And this conclusion stands even in the 2014 analysis, that it should be an alternative to whole breast radiotherapy. So the main hypothesis and outcomes were that the biological hypothesis that microscopic cancers can be left alone and EBRT may not affect them. Second, local recurrence is non-inferior with a non-inferior margin of 2.5%, and mortality may be different. So this is the randomization of risk-adapted radiotherapy. It is not just intraoperative, because if patients were found to have additional risk factors postoperatively, we could add external beam. This is a facility that allows individualization of treatment for patients. So that is the important thing to remember. These are not trial violations. These are part of the trial, and so we expected 15% patients to get both target plus EBRT. And that's what happened in real life. Remember, MRI was not required. This was a protocol published in 1999. And these are the most relevant results. First, the biological hypothesis. So the three-dimensional analysis had shown that 2/3 of breasts have other cancers and 80% are in other quadrants. Therefore, 63% of 80%, that is about 50% of patients, should have cancers in other quadrants, which are being left alone if you give only partial breast radiation. In TARGET trial, there were 803 patients who did not receive external beam radiotherapy. They were randomized to receive TARGET during lumpectomy. So you should expect 405 patients to have cancers in other quadrants. Breast MRI was not done, so we didn't exclude those patients whose tumors might have been found on breast MRI. So we had 2,077 women years of follow-up. There were 7 recurrences in the scar, 6 recurrences in the other breast, and of the 405 foci of cancer in this follow-up period, only 2 have recurred. So this is the series of those patients in the trial without comparison. But if you look at the randomized evidence, you can see that patients randomized to TARGET versus those randomized to EBRT, the number of recurrences in other quadrants is 2 versus 2. So clearly, even if you give radiotherapy, external beam, whole breast radiation, it doesn't stop those 2 recurrences. So I think that is a QED, that giving TARGET only to the peritumoral tissues does not jeopardize local control, and we have strong support for the main hypothesis which started the trial. So now for the other results of local recurrence. Remember, the TARGET trial was in 2 strata, pre-pathology and post-pathology. Pre-pathology means patients were randomized before patient had lumpectomy. This is how the TARGET trial started and was that way for first 4 years. But after Australians joined the trial, they found it logistically difficult to do it. So they asked us, could we randomize after lumpectomy and reopen the wound to give radiation to the tumor bed? We said yes, being pragmatic. We thought they might do better because they had better patient selection, perhaps. But we can see how the results have panned out since then. But 2,298 patients were randomized in a manner that was originally decided, and that number is bigger than the original number as well. So what is the test for non-inferiority? With a rather strict non-inferiority margin of 2.5%. So this is what is published in the Lancet. Overall, for the whole trial and for the patients who were randomized before lumpectomy, we found TARGET was non-inferior. A p-value of less than 0.05 means that it is non-inferior. So you can see that, and we then tested this, restricting the analysis to the patients who were randomized in the first 8 years. So these patients had a median follow-up of 5 years. And that number is still 1,222. So 1,222 patients in the TARGET-A trial had a median follow-up of 5 years. Restricted analysis to these patients also found non-inferiority over the whole trial, as well as for pre-pathology, but unfortunately not for the post-pathology. So since these results have been announced, people in Denmark and Australia are moving towards using it during lumpectomy, which makes sense. So these are the results in pre-pathology. And this gives a perspective that most patients don't recur, whether they are pre-pathology or post-pathology. You can see the recurrence rates are low, And in pre-pathology, the difference is not significant and non-inferiority is proven, whereas for post-pathology, the difference is more than 2.5%, although not statistically significantly different between each other. So this graph you probably have not seen before. It is published in the Red Journal this month. It is in the article is manuscript accepted. So this is a 5-year local recurrence-free survival, and which shows that there is no difference between the two groups. If at all, there is a trend that the blue line is slightly above the red. But it certainly is no different. There were some concerns that maybe patients who randomized to TARGIT got good results only because some of them, the worst of them, got whole breast radiation. But that is not true. This table shows the right-hand side, the pre-pathology patients who received TARGIT alone versus the post-pathology patients who received TARGIT alone. You can see that these patients had worse prognosis cancers, fewer less than 1 centimeters, fewer grade 1s compared to post-pathology, more node-positive patients. But their local recurrence was no different from the whole group of 2.7%, whereas the local recurrence, when you give it delayed on average 37 days, it is more. So it is not because of additional of external beam radiotherapy that we've got good results in TARGIT in a pre-pathology group. So therefore, TARGIT during lumpectomy is non-inferior to EBRT with a margin of 2.5%, and P of non-inferiority is really very high, and difference in 5-year local recurrence is not statistically significant at p.31. We did a subgroup analysis, and in this, the only factor that was found to make a difference was hormone receptor status. So if you have patients who are hormone receptor positive, and these are usually the patients we are going to treat, you find that there is no material difference between the two arms of the trial in terms of local recurrence. I'll talk about the deaths in a minute. The difference in death has remained. It seems to be tending towards having lower mortality with TARGIT. And this is another way of showing the same result. You can see that whether you restrict yourself to those with median follow-up of 2.5 years or to the first few patients who had median follow-up of 5 years, and few is not small, you find that there is no absolute difference in local recurrence, but there seems to be a tendency towards a difference in survival. So what is the disease-free survival? The disease-free survival for TARGIT trial between the two arms is the lines are on top of each other. This is for the whole trial as well as for the pre-pathology group. So it seems to be as good. Deaths. Deaths is an important outcome. It's particularly important because in this trial we had 88 deaths and 34 local recurrences. And the number of deaths from other causes was 52. So more patients died from other causes, non-breast cancer causes, than they even recurred. So deaths cannot be ignored. Might TARGIT save lives? I'm going to talk something which may prompt you to say, is he gone crazy? So this part you have heard, that all deaths, there seems to be a tendency to a trend towards reduced mortality, and the difference is statistically significant for non-breast cancer deaths. And we were puzzled. We tried to analyze in every possible way to try and make this result go away, but it wouldn't. So it remained and remained. And it seemed to be because of difference in mortality from cardiovascular causes and from deaths from other cancers. And we remember, by the time we started the trial, cardiac sparing was already introduced. This paper is published in 2001. So cardiac sparing was used during the TARGIT trial. We know from the New England Journal paper from Darby et al. That risk of ischemic heart disease is higher in those who received whole breast radiotherapy, risk of second breast cancer is higher, and these are rather lethal cancers when they come up. And they also showed that cardiac toxicity does appear in the first 5 years. So why have we not seen this in other trials in the past? Perhaps because in those trials, by the time 5 years came, 50% patients were dying from breast cancer. So in the trials where this data was first found, half the patients were dead in the first 5 years from breast cancer. It was a high mortality disease in those days. Now, 2 to 3% people die from breast cancer. So because the difference, the mortality from breast cancer is small, we are finding this small difference in non-breast cancer mortality has surfaced in the TARGIT-A trial. This is what we believe is probably the reason why we have seen it now. It may not have been apparent if many more women had died of breast cancer. The trial size is not small. That is a TARGIT-A trial compared with other trials which have changed practice. Even TARGIT-A pre-pathology is a large trial. The follow-up has been a question asked many times. There is the known fact that local recurrence after breast cancer treatment keeps occurring for many years, particularly if they're good prognosis cancers. Yes, it does. However, how long is the effect of radiation? And this paper from the Swedish trial published in JCO shows it very nicely. And their conclusion states very clearly that reduction in local recurrence because of radiotherapy is limited to the first 5 years. So as you can see, these two lines, most of the difference between these two lines of radiation versus no radiation has occurred by the time 2 and 2.5 years have passed. After 2.5 years, there is a slight more separation. But after 5 years, the two lines are parallel to each other. They keep recurring, but they recur at the same rate whether you receive radiotherapy or didn't receive radiotherapy. So the effect of radiation on local recurrence is limited to first 2 to 3 years, perhaps up to 5 years, but not longer. And you can see that much better in the letter that they wrote, in which they plotted this as a hazard. Hazard reduction because of radiotherapy. You can see that the curve bump is in the first 5 years. And when you plot that in terms of numbers, this is how it looks. The hazard reduction is in 0 to 4 years. After that, radiotherapy doesn't have an effect on local recurrence. So you don't need to wait for longer than 5 years to decide whether this particular effect of radiation is there or not there. So whatever difference was going to occur at 25 years was already seen at 5 years. Elliott trial has 1,300 patients with a median follow-up of 5 years, and TARGIT-A trial also has 1,222 patients with a median follow-up of 5 years. In addition, there are other patients with shorter follow-up. And it doesn't dilute the effect, it increases the data. One other question that has been asked is no radiotherapy an option? So here are the trials, CALGB from BASO-2 and PRIME-2. In all these trials, they were highly selected patients, node negative, ER positive, low grade. And what was their 5-year local recurrence rate? 1 in 25, 1 in 17. Do I want 1 in 17th patient of mine to get a local recurrence? If you use TARGIT, what you find, these are patients with no restriction. None of these restrictions were there, and we get a 2.1% local recurrence. If you put a restriction, a single one, ER positive, then you have a 1.4 versus 1.1. 1 in 71 of the patients who receive TARGIT in the correct group will get a local recurrence, compared with 1 in 17 if you give no radiation. Is that really what we want to do, no radiation? I don't believe so. Now this is a bit of a cartoon here, saying that TARGIT IORT should be standard of care because randomized evidence shows this. So these are patients who are been diagnosed with breast cancer, and they have been randomized to receive TARGIT or EBRT. These are 100 patients on each arm. And this is what we found without any corrections for selection bias. So this is 1 versus 2 recurrences. And those are the people who died. So it's 1.4 versus 3.3 deaths, and local recurrence is 1.2. And this is a less dramatic figure, which is published now. You can see what would happen to 1,000 women at a time of TARGIT at a time of lumpectomy, what happens to them if they receive TARGIT at 5 years. So these are various reasons which are there for giving TARGIT during IORT. It's more convenient, it's easier, less expensive to the community, relatively simple to deliver, it's quicker, individualized, it's accurate, there's randomized evidence to support it, it saves time and money, and may save mastectomy. I'll give last 2 slides on TARGIT boost. In younger and higher risk patients who still have a high risk of local recurrence. So this is EORTC data, which shows that in young patients, recurrence rates may still be high, even with a boost. So TARGIT may improve this because it is given at the right time, at the right place, and accurately delivered when wound fluid may cause harm. And I'll tell you how that could come. This was a study done in Italy where wound fluid was taken after lumpectomy and put on breast cancer cell lines. And what we found is that this fluid is stimulatory to cancer cells. It increased their proliferation, motility, and invasiveness. And what was a good surprise is patients, if they received intraoperative radiation, this effect was abrogated. So TARGIT abrogated the stimulatory effect of wound fluid on cancer cells. You can see that in this one, where these are cells moving around in bathing wound fluid, moving around actively, whereas if these patients, the wound fluid is from a patient who received TARGIT, they don't move around as actively. And objectively, that's what it shows in the graph, and this was published in Clinical Cancer Research in 2008. And this is probably because a difference in the wound fluid proteins that are altered by target, as you can see there. Now, some of these may get absorbed systemically. What might they do? Let's think about that in a minute. The long-term follow-up of the first phase 2 trial was this, that 300 patients, unselected patients, with many of them being grade 3, many of them being node positive, many more than 2 centimeters, we found that the local recurrence is 1.7%, half of what would be expected, less than half of what would be expected. So these clinical data led us to get funding for the Target Boost trial, and I would really urge every one of you to try and put patients on this trial, which is randomizing patients to receive an intraoperative boost versus external beam boost postoperatively. Everybody gets whole breast radiation. These are patients who would not otherwise be suitable for Target as a single treatment. So they're young patients or those with higher risk. 20 centers are already randomizing, and accrual is going fast. So we want to have about 50 centers to get to the accrual goal of nearly 2,000 patients. Now the mortality difference in Target-A trial. This is the last part. So we know this result, and we know that these are the causes. So we wondered whether EBRT toxicity was responsible for the higher non-breast cancer mortality or not. Now within the Target-A trial, you know that some patients received EBRT when they were randomized to receive Target. So this is patients received Target, then received EBRT. These patients received EBRT. If you compare this group with that group, the difference is in terms of breast cancer aggressiveness. That's why they received external beam. But there shouldn't be a difference in non-breast cancer disease in this group. So comparing this group with that group is Target plus EBRT versus EBRT. It's non-randomized comparison, but what did we find? The only difference in these two groups was Target. And this is what we found. So these are 218 patients. There were no events, and there were 24 events among 890 patients. And this was statistically significant. So it suggests that the difference between the two is just Target. So is that wound fluid doing anything good for these patients? It seems rather strange. I fear being called crazy after I show this slide, and maybe many people will be thinking that way. But this is only generating a hypothesis and can be a source for doing translational work of wound fluid and body fluids taken at a time of lumpectomy to see if it has any cardioprotective and neoplastic death from cancer protection effects. You remember, aspirin is 75 milligrams of aspirin, which is 1 part per million of a human being. 1 part per million, given at the right time, saves lives. So maybe this makes a difference. So this hypothesis would be tested again in the Target-B trial, because there the difference is only in the time patient is getting radiation. And we are collecting data for these during the trial as well. So we are moving from vision to reality of having patients who are otherwise suitable for Target-A trial to receive Target as a single dose and add external beam if necessary. And for patients who are younger than 45, I urge you to participate in the Target Boost trial to test whether it is superior in terms of cancer control. Thank you very much, and we hope. I think we have 5 minutes.